Another one doubt.
Okay, so that has completed the management of stroke. So before proceeding to the last topic, which is TA, we'll just brush some aspects. We'll just discuss some aspects. So I'll ask few questions. So we'll discuss based on that. So in one slide, Aravind was mentioning about how to clinically identify whether the symptoms are due to hemorrhage or due to ischemia. So can you elaborate that again?
Yes, sir. Mostly the deficit at the time of onset will be maximum ischemic stroke, sir.
Hmm.
Whereas in hemorrhagic stroke, uh, again, it worsens over the period of time.
Hmm.
Again, in hemorrhagic stroke, the level of consciousness is more depressed
Hmm.
when
I
compared to
think I
ischemic
think I
stroke.
will have some controversy here because they say there are three types, right? Thrombotic stroke,
Yes, sir.
embolic stroke, which are both subset of ischemic stroke. Then we have hemorrhage. Usually they
Yes, sir.
say hemorrhagic stroke and embolic stroke will present with maximum weakness at the time of onset. Usually
Mm.
they say hemorrhage and embolic stroke presents with maximum weakness at that time. Whereas thrombotic stroke is called as stuttering onset stroke. So initially occlusion will be mild. Then as the occlusion progresses, weakness also will progress accordingly. So in thrombotic stroke, weakness will be minimum at the beginning. Then it will try to progress and it will reach its maximum to one end. Whereas in embolic or hemorrhagic stroke, weakness will be maximum at the onset. Similarly, in terms of recovery, usually ischemic stroke will have a very prolonged and prolonged recovery. Hemorrhagic stroke will have a rapid recovery because the basic treatment in hemorrhagic stroke is only anti-edema measure and BP control. So it is easy to treat hemorrhagic stroke. It is difficult to treat ischemic stroke. So that is what they say. Also, ischemic stroke usually follows the symptoms of arterial territories. So why we spend so much of time in discussing all those territorial things and symptoms is ischemic stroke follows a particular arterial territory, whereas hemorrhagic stroke doesn't. And you would have known the three common sites of hypertensive bleed, right? Cerebellum, pons, and thalamus. So hemorrhage doesn't usually follow the arterial territory, whereas ischemic stroke, both embolic and thrombotic, follows particular arterial territory. Venous stroke, that is cerebral venous thrombosis, is also an infarct, but it is actually a hemorrhagic infarct, and it doesn't follow arterial territory. So if you are seeing at a CT film, there is hemorrhagic infarct, but it doesn't follow in arterial territory, then you can think that it could be a venous stroke. Okay. So I think that will be answering this question, how to clinically assess whether it is ischemic or hemorrhagic or CVT by the symptoms. So since we finished here, I'll ask one more question related to this. Somewhere you mentioned the indications where you can use contrast CT in stroke, right?
Sir,
You mentioned somewhere the indications of contrast CT in stroke,
contrast and CT.
contrast enhanced CT in stroke. That is again in CVT only. If you're having
Oh,
a
okay,
doubt
sir.
of CVT, CVT will usually present with headache,
Yes,
and
sir.
they'll be having that risk of CVT. Uh, they may be taking OCP. History of COVID infection itself is a risk of CVT. So in that case, CT contrast enhanced CT will be good to visualize the venous structures. Otherwise, we have discussed previously itself. Nowadays, CT angiogram is very important. Try to do an angio imaging, whatever is possible, because endovascular thrombectomy is nowadays becoming an option. So we should know about the large vessel anatomy. So that's about that. And some discussion about the time window. So what is the time cutoff for thrombolysis, IV thrombolysis?
Sir, door to
Hmm.
needle time should be less than 20 minutes. Window period is 4.5 hours.
So from the onset of stroke till they present, like 4.5 hours. Before 4.5 hours, you have to thrombolize. That is the time window. But is there any different time window for posterior circulation stroke?
Yes, sir. Uh,
Yeah, I
they say
mentioned
even
it
up to
somewhere down.
24 hours.
Yeah,
Yes, sir.
I think in one of the slides of thrombectomy you are mentioning. You can put that slide if.
Yes, sir.
Yeah, so the
Along
classically
with
what is described
thrombectomy,
is, yeah, that door to imaging time should be less than 20 minutes. Door to needle time is less than 20 minutes. And they say if we need to go for thrombolysis, the decision should be taken within 5 minutes. So within 4.5 hours of onset of stroke, thrombolysis is an option. Less than 6 hours, thrombectomy is an option. That is what is usually said. But now the trend is changing because in addition to doing just a CT or MRI, we have an advanced imaging which is called as perfusion imaging. So we can demonstrate something called as diffusion perfusion mismatch. So in MRI or even in
yes, sir.
CT. So I'll tell what is that diffusion and perfusion mismatch. That is, the perfusion to a particular part is affected, but the diffusion is not present, which means the blood supply is occluded. Definitely, there's a large vessel occlusion, but still the tissues did not go for infarct still. That is something called as diffusion perfusion mismatch. If we are able to demonstrate this entity in MRI, which means the tissue is salvageable, it has not gone for infarct, there is still an ischemic penumbra. But most of the time, the diffusion perfusion mismatch cannot be measured in MRI. It may not be available in many centers. So an equivalent to that is uh, they'll say something called uh, T2 diffusion mismatch. I'm not sure of the term, sorry. Uh, uh, like it's similar to this one only. Like T2 intensity has not developed much. Uh, like that, they'll say. In that case, you can go for thrombolysis. Similarly, we have the CT perfusion imaging. So in these cases, and in wake up stroke, patient wakes up with a stroke. We don't know what is the actual timing of onset of the stroke. In those cases, you can consider IV thrombolysis even for a longer time, even up to 24 hours, or based on the imaging finding, diffusion perfusion mismatch. And similarly, posterior circulation stroke, we can go up to 24 hours. Similarly, the time interval for thrombectomy also up to 24 hours. If there is salvageable brain tissue, it is not 6 hours, it is 24 hours.
Yes,
That
sir.
is T2 flare mismatch. Sorry, I was trying to tell about T2 flare mismatch. Okay, so in MRI, we can either look for a diffusion perfusion mismatch or a T2 flare mismatch. Okay, next thing is so one thing we have to remember is the timing has completely changed. It is not just 4.5 hours. So even if the is coming after 4.5 hours, if you are having an MRI, if diffusion perfusion mismatch can be done, that is okay. If not, a plain T2 is enough. If there's a T2 flare mismatch, that is T2 is showing hyperintensity, but flare is not showing a hyperintensity, then also we can opt for thrombolysis. Or if you are having a CT perfusion imaging, we can demonstrate the same there. Infarct has not developed, but CT perfusion is showing an abnormality. In that case, you can go for thrombolysis. Similarly, if these abnormalities can be demonstrated up to 24 hours, we can do a uh, for a large vessel occlusion, we can do a mechanical thrombectomy. For posterior circulation stroke, even up to 24 hours, we can do thrombolysis plus thrombectomy. The reason they are given here is uh, high mortality. But the one more reason is which we had discussed in the initial presentation itself. Anterior circulation and posterior circulation both are different. So anterior circulation is more prone to ischemia, whereas posterior circulation is resistant to ischemia. So we can take the risk. So with this, we discussed about wake-up stroke and the imaging, the time interval controversy. Then what are the two agents which can be used in thrombolysis?
Sir, multiplies and tenecteplase.
Be sure of the dosing, because
Sir,
tenecteplase, nowadays tenecteplase is preferred in many centers than alteplase because it is given within 5 seconds. But be careful of the dosing. In cardiology, usually it is 0.5 milligram per kg IV bolus, whereas here it is even half the dose, 0.25 milligram per kg bolus. So a 50 kg person, 12.5 will be enough, right? So a
yes,
lower
sir.
dose of tenecteplase is what is given. But there are no head-to-head comparison trials of alteplase and tenecteplase. Like many trials have done with only tenecteplase, with only alteplase. Both are effective, but there is no head-to-head comparison. So if someone asks you which is better, which to opt, tenecteplase or alteplase, we won't have an answer. The only thing is minor differences in cost and the speed of administration. Tenecteplase can be given very short, so no need for that 1 hour monitoring. That is the only difference. Otherwise, the basic thing is any thrombolysis, after any thrombolysis, they are prone for bleeding. So up to 2 hours, we are not supposed to catheterize the patient, and we should monitor cuff BP. I think there's some timing also given. Every 15 minutes for the first 2 hours, then every hourly for the next 24 hours. That will be the timing for BP monitoring. And BP cutoff is very important. It should never cross 160/90. So proper BP monitoring should be there. And no antithrombotic or anticoagulation should be done for the next 24 hours. So if you are thrombolizing,
Yes, sir.
don't give heparin in between. The next dose of heparin should be given only after 24 hours. Whereas in cardiology, it is different. In cardiology, after thrombolysis, first dose of heparin should be given after 6 hours. Whereas in stroke thrombolysis, after thrombolysis, first dose of heparin should be given after 24 hours.
Yes, sir.
Okay. And I think you didn't mention about NIHS stroke scale, right?
Yes, sir.
Like it's a,
Severity.
yeah, to describe the severity, it's a point 42 point score. If NIHS is less than 5 or more than 25, then there is no need for thrombolysis. Less than 5 is a minor stroke, not indicated for thrombolysis. More than 25, severe stroke, moderate to severe stroke. In that case also, there is no need for thrombolysis because risk of hemorrhage is more. So NIHS should be documented in any ischemic stroke. And suppose you have done, and you have done a repeat CT, CT showing a hemorrhagic transformation. So will you stop anticoagulation? Will you stop antithrombotics? In somewhere you mentioned following hemorrhagic
Yes, sir.
transformation, you have to stop anticoagulation and only aspirin should be continued. Somewhere you mentioned.
Yes, sir.
Yeah. So because hemorrhagic transformation actually marks successful treatment. That is an occlusion. We are giving aspirin or we are giving a treatment and we are opening up the occlusion. So minor hemorrhages are accepted. In fact, that indicates reperfusion to the area. So hemorrhage is actually good. But don't give anticoagulation if there is hemorrhage. We can continue antithrombotics. Suppose the hemorrhage is very excessive, severe enough to cause uh, in fact enlargement of the size or severe enough to cause edema, what is a mass effect. In that case, you can consider stopping aspirin. Otherwise, stopping anticoagulation alone is enough. So that is about the third situation. And I think for the second point, APLA syndrome, APLA is a place where we anticoagulate, right? I will go for anticoagulation.
Yes, sir.
Like anyway,
Okay.
anticoagulation and antiplatelets, we are going to give that. Okay, so about, okay, suppose you told one BP cutoff before thrombolysis, BP should be 185, 110. It should never be more than 185, 110.
Mm.
What if patient comes with a BP of 230/130? We are opting for thrombolysis. What agent will you use to reduce the BP?
Short acting antihypertensives,
Beta
like
block, lebitlol.
beta block levodopa.
You should not give NTG because NTG is a vasodilator. Vasodilator can increase edema in the brain. So lebitlol only should be used. Okay, so I think these are the points I wanted to discuss.
Okay.
Okay, so I think we can continue with TAA now.
Ah,
In our hospital, we follow that uh, flare flare mismatch. T2 flare mismatch we commonly use in our because in nearby centers
class
we don't have.
நடக்குதுன்னு sound. Sir?
In our institute, we commonly use T2 flare mismatch to decide whether to give a thrombolysis or not because we don't have diffusion in nearby MRI centers, diffusion perfusion assessment. So T2 flare mismatch will be okay. Okay, so we'll go with TAA. And one more
Okay.
controversy, which agent to use, which antiplatelet to use. See, that chance trial was telling it had initially given clopidogrel plus aspirin for 21 days. Then
Yes, sir.
clopidogrel for was continued. In
Yes, sir.
point trial, same thing, same dual antiplatelet was given for initially, and then aspirin was continued. But most of the studies
Mm.
say that aspirin is better than clopidogrel, and there are actually many combinations which are tried. Ticagrelor plus aspirin, clopidogrel plus aspirin.
Sir,
But
I
the
have
point, yeah, so this is
regarding
chance trial.
secondary prevention you're telling, sir.
Yeah, secondary prevention.
I have like I have slides to discuss
Yeah,
that.
slides on that.
Go.
Okay, so we'll
Yes.
continue with it.
Um, Transient ischemic attack.
Hmm.
Again, focal neurological deficits of vascular origin, which lasts less than 24 hours. Sir, this nice guidelines, they suggest to take MRI brain uh, within 1 hour of symptom onset because they say unless CT is offering some alternate diagnosis or if there is clinical suspicion of alternate diagnosis, uh, better to go with the MRI brain than CT brain is what they suggest. Especially diffusion weighted and blood sensitive sequences can pick up the territory of ischemia in MRI on to detect the hemorrhages or alternate pathologies. Again, another point to note is this. So we have scoring systems like A, B, C, D to score to assess the risk of subsequent strokes in patients with the TA. Sir. Again, they are against using these scoring systems so that all patients with suspected TIA or confirmed TIA get urgent neurologist consultation and they can be done the needful, especially within 24 hours of symptom onset. This CHAD TS2 VAS scoring system for, as you know, for assessing the stroke risk in patients with atrial fibrillation, where C stands for congestive heart failure, H stands for hypertension, A stands for age more than 75 years, P for diabetes, S for stroke or TIA or thrombotic event, or any other vascular disease, age between 65 to 74, and the female sex, out of which all criteria satisfies one and age more than 75 and previous stroke or TIA includes 2, and the score of more than 1 is in more than or equal to 2, oral anticoagulation is recommended, and the score of 1 it depends upon the patient's risk. Again, this scoring the advice to do periodically, that is dynamic scoring should be used to get the full benefit. Again, the scoring, I don't know whether it is obsolete now because NICE 2022 guidelines does not suggest to use this in case of TIA. Again, we all know the risk factors of stroke and TIA and its role in primary and secondary prevention. Again, SPRINT trial is a systolic blood pressure intervention trial that keeping the blood pressure less than 120 is known to decrease the incidence of stroke. Again, SPARKLE trial, like this deals with the dyslipidemia part, that is aggressive reduction cholesterol levels. Again, reduces the incidence of stroke. And Jupiter trial, again, this is another study for use of statins in prevention of stroke. Again, just got good results in reducing the incidence of stroke. Antiplatelet agents as a preventive measure in stroke. As we all know, aspirin is the most commonly used antiplatelet agent. It inhibits platelet cyclooxygenase, thereby inhibiting thromboxane A2. It inhibits it irreversibly, so it lasts for up to 8 days of the platelet cycle. On the other hand, it also inhibits endothelial prostacyclin, which is transient. It lasts only till aspirin is cleared of blood. So low dose aspirin given once daily inhibits the production of thromboxane A2 alone without inhibiting prostacyclin. So it is effective in stroke prevention. Again, it is inexpensive. So again, adverse effects include epigastric discomfort, gastric ulceration, and GI bleeding. Moving on to next antiplatelet agents in stroke prevention, clopidogrel and ticagrelor both block the adenosine diphosphate receptor on platelets and thus prevent the cascade resulting in activation of glycoprotein 2B3A complex. We have CAPT trial, that is clopidogrel versus aspirin in patients at risk of ischemic events. Found out that it is only clopidogrel is only marginally more effective than aspirin in reducing the stroke. Long-term use of combining clopidogrel with aspirin for stroke prevention is reported to have increased risk of hemorrhage and death with no significant benefits. So hence it is not recommended. Similar results are obtained for ticagrelor also. Then we have dipyridamole, which inhibits the uptake of adenosine by a variety of cells. This accumulated adenosine in turn inhibits platelet aggregation. In turn, adenosine also potentiates the anti-aggregatory effects of prostacyclin and nitric oxide. It has got better oral bioavailability when combined with aspirin because aspirin reduces the pH. This combination has been studied in ESPS2 trial, that is European Stroke Prevention Study trial, where it showed a significant risk reduction in preventing stroke when the two agents were combined. In PROFESS trial, that is prevention regimen for effectively avoiding second strokes, extended release dipyridamole and aspirin was compared directly with clopidogrel which found no significant difference in the rates of second stroke. So, which antiplatelet agent to choose? Either aspirin, clopidogrel, or dipyridamole plus aspirin. Again, this has to be individualized. Take into consideration the risks and benefits, the cost, side effects, everything should be considered, and treatment should be chosen. Moving on to anticoagulation in AF. In non-valvular AF for stroke prevention, again, NOACs are the drug of choice. This is based on three trials. Aristotle trial, that is apixaban for reduction in stroke and other thromboembolic events in atrial fibrillation. Again, it showed results in reducing the risk of stroke. Again, however, the using NOACs resulted in increase in bleeding, but when compared to the risk of stroke and the percentage of bleeding, we prefer to use NOACs. And Rocket AF trial, where rivaroxaban 20 mg once daily dose was compared with vitamin K antagonists, and it showed superior results. And Relay trial, dabigatran 110 mg, 150 mg was compared with vitamin K antagonists, and it showed that dabigatran at a higher dose, that is 150 mg, was superior to warfarin, and dabigatran at 110 mg was the least one causing bleeding among all three agents. So, in patients who are having AF, for whom vitamin K antagonist therapy are unsuitable, clopidogrel and aspirin has been studied. This is active A trial. Again, it reduced the risk of major vascular events when not treated, especially stroke. And again, however, using antithrombotics antiplatelets increased the risk of major hemorrhage. This point, sir already mentioned, like intermittent AF or transient AF are causes of many of the cryptogenic strokes, because this seems to be episodic and patient may not present to us with the AF. So anticoagulant agents in recent acute coronary syndrome or primary coronary intervention for stroke prevention per se, there are different trials. Following acute MI, especially when there is anterior Q wave infarction, substantial left ventricular dysfunction, congestive cardiac failure, or a presence of a mural thrombus or AF, the patient is at risk of developing stroke. So, in this scenario, we have agents which has been tried for stroke prevention. In Uprise 1 trial, apixaban was studied when treated against placebo. However, apixaban got a dose-dependent increase in bleeding. However, it reduced the risk of ischemic events. But in Uprisal 2 study, apixaban at full dose, that is 5 mg twice daily, in patients with AF following MI, there was increase in bleeding risk since this was not continued. Again, a similar study was done with rivaroxaban in Atlas ACS TIMI 46 trial. Again, it has got benefits in reducing the risk of strokes, as well as, again, on the other hand, it causes significant bleeding. But overall, rivaroxaban, when compared with apixaban and rivaroxaban at different doses, rivaroxaban 2.5 mg twice daily demonstrated an overall mortality benefit. So it prevented both stroke, and the risk of hemorrhage was also lower. So there was no head-to-head trial comparing NOACs with vitamin K antagonists in acute MI events in stroke prevention. There were three main trials, like Pioneer AF PCA trial, Redual PCA trial, and Augustus trial. They all compared Novavax with vitamin K antagonists because in acute MI, the patient may already be getting aspirin and P2Y2 inhibitors. In addition, is the addition of anticoagulant agent, either rivaroxaban, apixaban, or dabigatran, or vitamin K antagonist. Does this satisfy the risk of stroke reduction while uh, not increasing the risk of hemorrhage? Was the trial. So in all these trials, addition of Novavax add better outcomes. It reduces the risk of stroke as well as without causing major bleeding. So even trials were studied with single antiplatelet agents, like avoiding aspirin and trying only Novavax and P2Y12 inhibitors. So it showed superior results in many studies. So this was for a post-acute MI. Patients having rheumatic heart disease with atrial fibrillation, vitamin K antagonists are the drug of choice because Novavax are not studied in this population. Again, patients with mechanical heart valve requiring thromboembolism, vitamin K antagonists are the drug of choice. They have studied dabigatran, but it is less effective. Rivaroxaban and apixaban have not been studied. In non-cardiogenic cerebral embolism, for secondary stroke prevention, they suggest to use aspirin, except in two conditions. In cancer, apixaban 5 mg twice daily has been extensively studied and it is approved for use. And in antiphospholipid syndrome, warfarin with a target INR of 2 to 3 has been used. Moving on to treatment for carotid atherosclerosis. As we all know, carotid atherosclerosis is a risk factor for developing stroke, like AF. So we have interventions, both medical and surgical. There are few indications for carotid endarterectomy. So recent symptomatic carotid ischemia presenting less than 2 weeks. Significant stenosis, there is more than 70% luminal narrowing, and pertaining to hospital and surgeon, if the perioperative morbidity and mortality less, we can go for carotid endarterectomy. Two trials showed the absolute risk reduction for stroke in the operator group, the NASET and ECST trial, that is North American Symptomatic Carotid Endarterectomy trial, and European Carotid Surgery trial. Both showed absolute risk reduction. This is for symptomatic disease. For asymptomatic carotid disease with stenosis, the role of carotid endarterectomy is controversial. Again, decisions should be made on individual case basis. There are two trials for asymptomatic population.